So welcome to week 10. It's amazing. It goes by quick. This week, we really don't have any topics to go over, but what I wanted to do, and I've done for you this semester, is I made a brand new Kahoots, 89 questions. And how did I come up with questions for your HESI? Well, at the end of every HESI, they give us this printout of topics that were in a question. Now, I have no idea what the questions are, guys. But I know maybe it was like, for instance, Pavlik harness. So I'm going to give you questions about Pavlik harness. Now, does it mean those questions are on the HESI? No, but a question about it will be there. So if you're not understanding Pavlik harness, you can go back to the book and look at it. And I'm sure Jamie's can tell you the page number because she knows all of those sort of things. I'm teasing you, Jamie's. She's the detail girl. So with that being said, I think it's going to be a great learning experience. And you know how I give Kahoots. I'm going to tell you other information as we get going and going along. So as I said, there is a lot due this week. We have that discussion 8. We have those NGN case studies, A and B are due. We also have 2 case studies, which are a little bit cumbersome. It's the practice exam and assignment exam. These are to prep you also for your HESI. And then, of course, 50 more NCLEX questions. All of those are over 10%, okay? And especially those are writing on your grades, you don't want to even lose 10% on those, okay? So try to get them in by Sunday. Again, if something's going on in your life, you're in the ER, your mother, you're something, and you can't get them done, if you tell me before they're due, I can help you. You tell me after, I can't. And I've said that all along. So just, communicate with me. I'm always here for you. Yes, who has a question?
Kenya.
Okay. Yes, Kenya.
You gave me a 0 on one of my NCLEX because I submitted my my HERS questions instead of the NCLEX, but then I
I
resubmitted
believe
it.
I just did it.
Oh, okay. I was wondering if you've seen it.
I believe I just did it before class.
Oh, okay. Okay.
Okay. Anybody else have any things like that that I haven't looked at? Because up to now, except for discussion number 7, I've gone back and seen people resubmit and have looked at them. If you're seeing something there, like Kenya, I mean, I just did it half hour ago, about 45 minutes ago. So let me know. That's part of what this class is all about too, okay? All right. Signa, can you turn on your camera for me, please, so we can get going? Signa always has her camera on. Something's going on, or she stepped away for sure. Anybody have her phone to text her? All right, I'll give her a couple of minutes, and if not, I'll ask again. And when they don't come on, what you do is give them a chance, give them another chance, and you can remove them from the class if they're not on their camera. I don't like doing that, but I will give them that chance to do that. So let me get my Kahoots up and ready to go. Now, Kahoot.it, I do have Kahoots. I do redo them almost every quarter. Trying to look at HESI type of topics. I also look at the concepts in exams and quizzes and NCLEX, which it could possibly be. And I try to change these Kahoots. Now, you will be getting these, don't worry, Sarah and Bethany. I give these to everybody. I don't hold anything that I have. You all can use anything I have, not a problem. And if you want to play along, you go to Kahoot.it. You need a phone and you need a computer. And on the phone, you will push the red, the yellow, the green, or blue, whatever the colors are. And then you'll see the answers on the screen. So let's see who's the most prepared for the HESI right now. So who's going to win today? Debbie, do you want to win? Shabria, come on. How about you today? Yes, no? Signa's there. Good job. Welcome to see you. No, I don't have them put their real names there. Some of them are shy. I don't use this against them. It's just the way that they play. Some of those who like to win, you'll see their names there. The other ones are trying, but they know these Kahoots are very important and can affect their grades if they're really looking at them. I mean, every quarter I teach PNs. This is the second quarter. I've only done RNs for over 5 years, but I do keep changing these and trying to make them more and more rich and more full of those concepts. So let's go ahead, let's get started. So I said there's 86 questions, I think. 86, 89, 86, 80 something. So HESI review, here we go. A 1-year-old with pneumonia is placed in a mist tent with oxygen. Which nursing intervention has priority? Well, if you don't know what a mist tent is, it's this plastic that goes over the kid's head and it's tucked in so that there's moisture and there's oxygen in there. What are you going to be concerned about? This kid's underneath the tent. And the kid has pneumonia. What do you know about pneumonia? Upper respiratory, right? So one thing that can happen, you've got moisture going into their oral pharynx, right? It's going to loosen up that mucus and they could gag and choke. Not only I'm going to keep a bulb syringe there, I'm also going to make sure that I have something monitoring their oxygen saturations, right? They're underneath this tent. Could it foam? Could it fog? Yes, it could. So making sure suction's available at some sort and also monitoring that oxygen. The purpose of that knee chest position in children with tetralogy of Fallot is what? Remember, tetralogy of Fallot is that right pulmonary artery, for whatever reason, gets kinked, gets blocked, and blood can't go into the lungs. That means there's no oxygenation. That knee chest takes the abdominal cavity and the chest cavity pushes it together and it changes pressure and it pops open what's ever blocking that oxygen. I've told the students, I've seen it go from 100% sats to 10% within a minute. It's really quick, really, really scary. And that's the first thing. You don't need a doctor to do that. You see a tetralogy going into a TET spell, you are going to do that right away. You're caring for a child with tetralogy of Fallot who suddenly becomes cyanotic with SAT of 60. What is your first action to do? And yes, we are going to do a knee chest. Now, why doesn't oxygen work on this one? That seems like what you would do with low saturations, right? Well, no blood's going to the lungs. So it doesn't matter how much oxygen you put on by, a non-rebreather face mask. It doesn't matter. No oxygen is getting there. So knee chest, change the pressure, pop it open, let blood flow up into the lungs. What can cause rheumatic fever? There's two diagnoses in the pediatric world that can be caused by this. One's rheumatic fever, and the other is acute glomerulonephritis, which is the kidneys. So it's the strep throat. So what would be a question we would ask parents about rheumatic fever? And we're suspecting that. We're seeing the rash and the fever and the sore throat, and we're seeing the knobs of the joints getting wobbly, or maybe that chorea, that wobbly gait. Something's going on. We're going to ask, has your child been sick lately? And have they had a sore throat? And that probably was a strep throat that was not treated. A multi. Signs and symptoms of rheumatic fever include That's a little bit of everything. Now, the one thing that we cannot cure by treating the strep throat, which is antibiotics, of course, would be that heart valve damage. That's usually the mitral valve, that valve between the left atrium and the left ventricle. You can't fix it once it's damaged. It either needs medical treatment or surgical treatment. But everything else, even that unsteady gait, that chorea, can also, and those, weird type of movements, all of that can be corrected with treatment with an antibiotic. Another multi. Rheumatic fever and rheumatic carditis diagnostic findings. So that carditis, again, remember, that's that inflammation inside that joint, which is the heart, right? So if we have an itis, we're talking inflammation, right? Anything with an itis. So when we're talking about inflammation, we're talking about the SED rate, ESR, C-reactive protein. We use that a lot in newborn children, a lot. And of course, an EKG is telling us, is there something going on with that heart, the way that it's beating? It could be to that inflammation of the heart and that heart valve that it's affecting, okay? A VSD creates a left to right shunt with excessive pulmonary blood flow and pulmonary pressure, resulting in what? So if you have all of this flow going from the left ventricle, that's the muscle that's pumping everything, to the right side, and what happens? It goes back into that lungs because it just has to go back, keep going around and around and around. And what can it cause? Well, you are taking that lungs and putting high pressure constantly going into the lungs. And then and pretty soon the lungs say, this is too much. I can't handle this pressure. And it just tightens up. And basically, that's what happened in pulmonary hypertension. Oxygen, carbon dioxide can't exchange, and it just tightens up. And it could become permanent if we don't take care of that hole in the heart, that VSD, because of the shunting. I'll multi-select. Select all. Hypothyroidism, signs and symptoms. Students ask me all the time, what's the difference between children, hypothyroidism, and adult? And the only thing that's the difference is we monitor growth on children. It helps with the children grow, normal height, normal weight. Now, hypothyroidism, your body's not working as fast as it should, weight gain. You hear a lot of teenagers say, yeah, I haven't got hypothyroidism. That's why I'm a little pudgy, right? That's that weight gain. But cold intolerance, constipation, bradycardia, dry hair, sparse hair, all of these things that you're going to see with adults, you are going to see in children. So I'm sure some of you have heard that in med-surg also. What is parallel play? Who plays parallel play? We've learned a couple types of parallel play, right? Different sorts of play. Associative, cooperative, parallel, dramatic play, there's a bunch of them. And we describe them. Well, parallel play is they're alongside with each other, but they're not playing with each other. I mean, I'm playing here and she's playing there, and we're playing by ourselves, okay? That's next to each other, parallel play. At what age does a child begin parallel play? This is one group of children that you always see this in. It's a very normal. And this is all about toddlers, right? Toddlers don't play together. Mine, right? Me, mine. So I play with my own toys. As we get older, you'll see the associative or the cooperative play, okay? I'll multi-select. What type of infection is acne? And it's a local bacterial, and it's not fungal. No, viral wouldn't be something that would be a skin infection because there's an infection scene. Viral is your upper respiratory. That's where you see a lot of that. Even meningitis could be viral. But when you talk about acne, it's local, so it's localized. It's bacterial, so it needs good cleaning, right? Fungal, no, I think that's more like athlete's feet, right? It's not on the face, sorry. This medication treats acne and sinus infections. Well, we just said it's bacterial. Which one of these are good for a bacterial infection? And it's the doxycycline. That is the one specific for faces and acne. Now, penicillin is bacterial, but the one of choice is the doxycycline. A usual treatment for an infant with hip dysplasia is I think, Jamie's, this is the one that you were asking me about, that diapering, wasn't it? Yeah. And this is that Pavlik harness. Now, a body cast is not infant. It's an older child that the hips don't go back into the socket where they are. This Pavlik harness is this little thing we put on top of a shirt or a onesie. And we're going to put it on 23 hours a day. That 1 hour that is off is when we bathe them and then redress them with clothes and inspect to make sure there's no rub downs or any irritation of skin that's there. But usually, because we know infants' bones, they're usually 2 to 3 weeks they're going to heal. So it's pretty quick. It should go back in. But if it doesn't by about 6, 8 months, you're going to see them, that spica cast, not body cast, spica. It's from the chest down to the knees. I'll multi-select. How do you diagnose hip dysplasia in an infant? I mean, this is the one that the doctor, first visit to the pediatrician with your brand new infant, takes the knees and rocks them up and backwards and saying, right? What's he looking for? Or what is he listening for? Well, positive ortolani, is there clicking going on? The folds in the buttocks, if one of that hip is up here, the fold's going to be up here and down here, okay? And then that leg is going to be shorter because the leg is up here instead of in the hip socket. Now, that foot pointing inward, probably an adult with a fractured hip. Usually you'll see that. That's that inward point. That has not to do with infant. It does not affect the way that their foot points, okay? Which of the following are included in the nursing care of a myelomeningocele? Well, what is a myelomeningocele? That's on the low back where it doesn't close, and the meninges and the spinal cord are pulled out and in this purple blob on top of the skin at birth. So what is our concern about that? Well, this is the child immediately we're putting on latex precautions, because many times they have a lot of decrease or no sensation from the waist down because those nerves are stretched, pulled up on the outside, and there's nerve damage, okay? So these children are placed prone. We're going to have them on their little tummies. We're going to be watching their backs, and we're going to be monitoring 2 things really important to make sure, are they moving? Are they not moving? Your neurological function and urine function. A lot of times they don't feel they have to go to the bathroom, so they fill up with urine. These sometimes are those children that will have those intermittent catheterizations every 4 hours forever because they don't feel the feeling. Most important principle of nursing care for a child with myelomeningocele. Just think, what's your most important thing? You've got this big blob of meninges and nerves sitting on the back, open up right there. What is your concern? And it's all about keeping it clean. So at birth, they put sterile normal saline on it, a sterile dressing on it, and we're going to be using gloves taking care of this child, not latex, of course. Our concern is keeping it clean and free from infection. That's your spinal cord. So you can imagine it could cause a meningitis if we're not careful. Yeah, Camelia, did you say something?
No.
Okay, I heard you. What priority nursing action must be taken to care for a baby with a myelomeningocele? And it's all about protecting that sac that comes out, right? That's our biggest concern. We don't want to create more problems. These children are usually normal. They are not, cognitively delayed. They're normal children. They'll be in wheelchairs, many of them, but they'll be in normal classrooms. They'll be going to the dances and going to graduations. These children are normal. I mean, I had one kid I took care of. I met him when he was 14. After having him as a newborn. And he just gave me a big hug and said, thanks for taking care of my mommy. I mean, they're normal children. The nurse is teaching epistaxis management to a patient. What would be appropriate? What is epistaxis? That's your nosebleed. Could be caused by many different reasons. The big thing is not to put your head back. Why wouldn't you put it back? I'm going to choke on that blood, right? Put your head forward. It can drip out of your mouth. But take your finger and your thumb and you just push it here. And they say 10 minutes, hold it. And if you take it off, it's still bleeding, you need to get some medical care. Call the doctor, go to the urgent care, go to the ER. They might need to do something else. And it might be telling us there's another problem wrong with that child. So just emergent care first, pinch it, stop the bleeding if you can. What medication would you question if a person has epistaxis? So if this kid has a history or is bleeding out of the nose, what medicine would you not give? Aspirin, right? Because what does aspirin do? It thins the blood. And we don't want that bleeding to be even more. And if you had a child that had nosebleed, we're going to ask, what medications are you on? And if they're on aspirin, we're going to tell the doctor. And the doctor will tell that parent and that child not to take it anymore. If a baby is diagnosed with epispadias or hypospadias, what would we need to teach the parents? Well, what are these things? Well, normally a male is born and the urethra comes out to the end of the penis, right? Well, in this case, it's either on top or on the bottom, anywhere. And they're going to have to do some sort of surgery and put it where it needs to be eventually, right? So one of the big things is all about, now just think if you were of the Jewish faith, and we do frisk, right? If you're Jewish, you can't. That foreskin must be left there because it's part of a plastic closure. They literally take the penis and flay it and open it up. Seriously, just like that. And they create a lumen and they'll put a catheter in there. And they'll use that foreskin as plastic closure to close it all back up. That catheter will remain there for 7 to 10 days after surgery. But the big thing on many parents, depending on culture, is they cannot do a circumcision and they need that tissue. When is surgery recommended for hypospadias, epispadias? When should you do it? And why are those months chosen for this? It's about 6 to 12 months. And the reason why, we want it completely peeing out the right place, right? Before potty training. And some kids at 12 months are starting to want to do those things, right? So we want it good and healed by the time they're going to be potty trained. So the goal, hypospadias, epispadias, surgery completed before we start potty training. Or else, can you imagine potty training squirting out the wrong way? It really wouldn't be teaching that poor child. What does folic acid do for sickle cell disease? Now we know folic acid is that neural tube deficit, myelomeningocele. That's why we take it before we get pregnant if we can, right? Well, in sickle cell disease, why is it used? It's all about making red blood cells. Because remember, sickle cell disease, those cells die quickly. Normally, I have seen a sickle cell crisis child come into the ER. The normal hemoglobin hematocrit that I've seen is 7 and 21, and that's a good one. And you should be a minimum of what, 12 and 36. So if we give them folic acid, at least we're giving them a chance not to get a blood transfusion. If we can eliminate one blood transfusion, it's better for the child, right? So folic acid is making new red blood cells. How does folic acid supplementation aid the child with sickle cell disease? So with what I just said, what answer do you want to give it? It's all about red blood cells and fighting anemia. Because what does red blood cells do? They carry oxygen and iron to the tissue, right? So if you don't have red blood cells, that kid's going to be really tired. And we don't want that to happen. We want that kid to have that energy. And without red blood cells, no oxygen, that kid is going to be tired. And especially if they're young, we want them to be able to eat and get proper nutrition. When measuring urine output on an infant, 1 gram of diaper weight is equal to what? 1 gram of diaper weight, it's how much urine? Now, when I started pediatric nursing, I thought this was a really cool thing. It was like, oh, okay, makes sense. And it's 1 gram is 1 ml of urine. You have a diaper, weighs 30 grams. Usually number 1 is 30 grams. And then you take a wet diaper off the infant and it weighs 60 grams. Your urine output, even if there's stool in there, it's considered output, it's 30 grams. Very easy, very simple. A multi-select. Pyloric stenosis signs and symptoms. What is pyloric stenosis? Isn't that little valve between the stomach and the small intestines, right? It's at the end of the stomach. And that food and that milk got to go through that to get into the small intestines so that it can be made into something that the body can use. And what do you see? Well, this is the kid that has what we call forceful projectile vomiting. You literally can hold this child up and put his face outwards, and they can hit 10 feet across the room. I'm talking, it's that forceful. But what's happening to these children? They're not gaining weight because they're not getting their food. It's not going down. And these kids are cry, hungry, 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 hungry. So what do you see with these children? It's that little mass, right? Olive size. I call it a marble too. And if I see a kid, they tell me it's vomiting across the room, I'm going to put my hand up underneath their stomach, right below their xiphoid process, and you can actually feel it. And I would make that child NPO immediately. Now, current jelly stool, that's intussusception, where the intestines go in and out. Abdominal distension could be due to many different things. A lot of times it's just due to fat and inability to absorb it in some of these diagnoses. Hypertrophic pyloric stenosis main symptoms is. So you get an infant into the doctor's office, ER, whatever, and they're saying, baby's vomiting. Usually they're 3 weeks to about 3 months old. And I'm going to ask if they're vomiting. Is it dribbling like this or is it going out across the room? And projectile vomiting, the treatment is send them in, get an ultrasound, see what it is for sure, and it's going to need surgery. And they do really well with no long-term problems with it. They just need to open up that pyloric valve to let food go down. Causes for autonomic dysreflexia. And this is all about urinary retention. So this is one of the things we're going to look at, in case of any spinal cord injuries. We're going to see the body stops and it's a urinary retention with this. Autonomic dysreflexia presents with what? And this is the child who has a headache, has high blood pressure, but bradycardia. Usually you think high blood pressure, you think a high heart rate too. It's not. It is low, high and low there with the headache. And then our concern, again, with these injuries is urinary retention. A multi. Nursing interventions for autonomic dysreflexia. This is the child that you're going to have to teach them that bowel training, how to hold it, when to, force the urination. Now, these children do have high blood pressure. We have to treat it. That's one of the medications, hydralazine. And the other thing is we can dangle their feet down. It somehow works with the body's nervous system. It works good that way. Just dangling the feet is something we can do very easily. Lyme disease is caused by an infected deer tick, yes or no? And I've seen a couple of cases of this where extremely difficult to diagnose, especially if you live in Florida. Like, where would be a deer tick, right? Especially in southern Florida. But yes, it is true. Many times you have to look at their past. Have they traveled out of the state? Where have they gone to? Have they been in woods? Those sort of things. And that actually was the case that we found. This one kid, nobody could diagnose. Lyme disease treatment includes you're bit by a tick, and it puts in this disease into your body. It's this really big, long name. I don't know the name off the top of my head, but it's Baraljalia, something of the sort. Anyway, we give doxycycline. That's exactly what's due for this one, and it does work. Cryotherapy, no, that's nothing that would be used. Nystatin is used for yeast, whether diaper rash or the fungus in the mouth, right? Thrush. What is the side effect of Lyme disease treatment? So doxycycline, what do you worry about? And it's muscle stiffness, soreness would be something that we would actually alert the child, the parents to, so they would be aware that this could happen. Select an appropriate snack to aid in osteomyelitis care. So if you have osteomyelitis, which is what? An infection of the bone. Osteo is bone. Itis, inflammation, infection. What are something that we should tell these children and parents? We can help in that nutritional part of it. And believe it or not, it's fruits and vegetables. And another thing, because they need protein, protein snacks too, but it's more of the fruits and vegetables in this case. Propranolol is used in hyperthyroidism and can decrease thyroid hormone synthesis. Well, what does that mean? This is a thyroid storm. The heart rate goes up, the temperature goes up, they get chest pain, they don't feel good at all. Too much thyroid was released. What is an OWAL? An OWAL is a beta blocker, right? So everything comes down, 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 down. So yes, propranolol, the other word is Inderol, absolutely is something that we actually do use. But it's not used for the thyroid. Remember, they need to have something like that, the PTU, that decreases the thyroid from coming out, okay? So propranolol is used for the condition when it happens, but not as an ongoing treatment. That's for the storm, okay? So hyperthyroidism, look at the question. Is it asking for one of those emergent treatment, propranolol? Absolutely. Or do we need just something to block the medication, that PTU, that medication? And remember that PTU medication for hyperthyroidism blocks or decreases that thyroid from coming out. Remember, one of the side effects is leukopenia, right? So we have to be considerate about infections and notifying the physician on that. What is the primary use of PTU in the management of hyperthyroidism? After that explanation, you know this one. And again, it stops, it blocks, it decreases the amount of thyroid hormone that comes out. And that's how we treat hyperthyroidism. Now, if we're finding that they're always going into these storms, which can be dangerous, they will take the thyroid out. And then they'll be on a replacement like levothyroxine forever. They will be considered hypothyroid for life, requiring it for life. Good job, guys. Symptoms of a UTI in children. It's all of this stuff. I mean, a kid who vomits has a fever and it's not eating. And sometimes UTIs, you don't even get a fever. They'll stop eating and you're going to see them vomit once. That usually is what you see in children. Now, if you get the fever and that urine that's foul smelling, of course, that will be the hint. But sometimes it's just subtle. Kids who are sick stop eating. That's always the first thing that you see. Kids are not like us adults. We'll eat no matter what. Kids don't. The recommended schedule for DTaP is what? Two months, 4 months, 6 months, 15 to 18 months, 4 to 6 years. This is 2, 4, 6 months, and that 15 months is part of that group of those medications that we give. Because remember, infants are born and they have mom's immune system, and it's going to wear off, and they need to make their own. So we hit them really hard, very quick. 2 months, 4 months, 6 months. I mean, the first one we give at birth, right? The hepatitis B vaccine, and then we will give it 2 other doses. But remember, DTaP is one of those 2, 4, 6 months, and there are several of them that go on like that. A usual treatment for an infant with hip dysplasia is what? Let's see if you remember now. Good job, Pavlik harness. Again, remember, 23 hours a day, right? A sign you may note when assessing developmental hip dysplasia. That one leg is shorter, absolutely. Gluteal folds are different, leg is shorter. Positive ortolani's, absolutely. Hearing that clicking when you click, click, click the hips. A multi. Which immunizations are required for school-age children? A little bit of everything, right? We want to protect children, not themselves, but everybody else too. Even your teachers you want to protect. So all of these are given. You know, the DTP, that's the one that's 2, 4, 6 months, right? And the 15 months. Measles, rubella, mumps, varicella, those things are given at that 15-month routine. And remember, varicella is that live vaccine. When don't we give live vaccines? When they're immunosuppressed, or if they're on steroids, right? Because you are immunosuppressed like that. And of course, polio is at 2, 4, 6 months also. A Pavlik harness must be worn. And it's that 23 hours a day, absolutely. You know, I've seen it work, just the harness work, then I've seen children go on to the spica cast. And if fit with DDH will wear a Pavlik harness, what are the appropriate nursing interventions? So we're going to be given, or we'll take off the harness for bathing. Yes, we will. I should change that answer. Administered spun baths, you know, we don't want to overextend those hips. We can do that also. And again, we'll be looking at the skin, making sure there's no breakdowns also. I think they told me there was 3 questions on Pavlik harness. Caregiver teaching for a patient with Pavlik harness includes. I think we know Pavlik harness very well now. So we're going to be checking for skin breakdown. You can hold these kids. There's no problem with it. You know, and the Pavlik harness abducts, you know, the hips up to where it needs to be. Okay, I forgot to mention that the last slide. Again, you can diaper around that harness. It's like underneath it. You don't have to go around it. You can go underneath it and get it in so they don't get themselves soiled. Nursing interventions and patient teaching for a treatment of head lice and scabies include. You know, my daughter and my son came home. Now, my daughter had hair down to her buttocks at age 5. Came home 3 times one school year with head lice. And her hair, her braid was that thick. It was amazing. I've never done so much. Oh, I got kicked off for a second. Sorry, guys. Let me go back to where we were. There we go. Remember with treatment for head lice, they have to treat any bedding anywhere because if not, these lice do hide, especially if you have like a lot of carpeting, They also have different things they'll tell you to do for the carpeting. I think, what was it? Arm & Hammer soap detergent. Actually, they told me to put that down on the carpeting to help. You let it sit there for a couple hours and then vacuum it up. You can use that for fleas in the house too. Which determined by a parent whose child has had head lice indicates the nursing education was effective. So we are going to make sure that they've washed everything. Now, yes, you'll check it, but once it's done, it's like 7 days later, I think the eggs could hatch. 7 to 10 days later, you can look at it, you can check them. But the most important thing is washing everything, hats especially, of course. A multi. Which of the following nursing care interventions are appropriate for respiratory distress syndrome in infants? That's a cute little baby, isn't it? So oxygen should be 90 or above. That's what's acceptable, okay? When it goes below 90, then it will need oxygen. It's according to your book. Maintaining the temperature on these children is, you don't want it too low. Believe it or not, if a child gets cool, their heart rate and everything will come down. I've seen warmers where the nurse forgets to turn the warmer on after they gave a bath and changed the bed. And you'll watch that heart rate slowly go down because they're cool. So very important, maintaining their temperature. And of course, anything that does with respirations, you want to make sure that you have suction at bedside in case that you need to suction. Which of the following is the mainstay of nursing care for bronchiolitis in children? The other word for bronchiolitis is RSV. Respiratory syncytial virus. It's the same thing. It's just a different name. And we don't use anything but saline, believe it or not. In infants, we don't want to give them the albuterol or steroids or salmeterol, any of those, we don't. We prefer keep the airway clean with suction, maybe normal saline aerosol before, loosens up that mucus, suction it out, and then they could feed. That's what they recommend. Leading cause of childhood poisoning. What do kids love to get into? You know, working in the triage area of a pediatric emergency room, I've seen a lot of kids come in doing some crazy things and eating the wrong things. And most of all, it's medicines. They like to take their Flintstone gummy vitamins and just eat, okay? Now, actually, that's not dangerous because eventually they'll urinate it out. What's dangerous if they have iron in it, then it becomes dangerous. Or when it's grandma's cardiac pill, right? Or if it's Tylenol, it'll kill your liver, right? Those are the things that are more dangerous. And one of the things we need to teach our parents is to have that poison control number to make sure if they take anything, they know what to do and do it quick. Teaching for prevention of a urinary tract includes all of the following except. Most common of all urinary problems in children is a urinary tract infection. And many times we can prevent it, can't we? Now, if they're an adolescent, it is not, you should, if they're having frequent urinary tract infections, you can say, well, if you're having sex, it is said that if you urinate immediately after, it can decrease the amount of urinary tract infections. It's been proven. We're going to write from front to back. Absolutely. Cotton underwear, no tight, cute little tights that the children, little girls like to wear. They shouldn't wear them. And we want to increase fluid intake on these children, not limit it. Very good, guys. A multi. Appendicitis signs and symptoms include most of the appendicitis children I've seen are usually your school-age children. And you can see them walking down the hall, holding their right lower quadrant bent over. It is that pain in that McBurney's point, right lower quadrant. And then if you touch it, let go, they're gonna cry. And they're gonna, again, be protecting that belly for sure. Bloody diarrhea, no, they usually don't have diarrhea with this. It's all the pain and the area where the pain is. So what would you do if a kid presents like that? First of all, nothing more to eat or drink. They need surgery, right? And they're going to need an ultrasound, and it will see where, look at that appendix. Appendicitis, signs and symptoms, pains localized right lower quadrant, pain improve with hip flex, nausea, vomiting, tender McBurney's point, yes, no. You're going to ask why nausea and vomiting. Nausea and vomiting is because of the pain. It hurts so bad that they want to throw up. And that's why you see that nausea and vomiting with it. And all the rest is absolutely true. Which parameters should the nurse consider while assessing a patient with cystic fibrosis? So remember what cystic fibrosis is. It's not just the one area confined to. It is two areas. It has to do with the mucus in the lungs. It becomes thick and they can't move it. And we need to do really aggressive chest physiotherapy, keeping that mucus moving out. And then remember, there's a problem with enzymes in the small intestines. It doesn't produce what it should. And they don't absorb fat. So they're losing calories too. These children usually are smaller, thinner, because they're not getting calories. So they're going to need their pancreatase enzymes before meals and for snacks, and they're going to get all this respiratory care. A nurse is assessing a toddler who has cystic fibrosis. Which of the following findings should the nurse expect?
Daddy.
And you're going to see steatorrhea. I mean, just think about, as I said, they're not getting what they need in nutrition because you're going to see their fat gone. You're going to see these very foamy, foul, malodorous smelling stools. Visible peristalsis? No, you're going to see abdominal distension because they're not absorbing fat in that. Weight loss, they're not getting it. And they're not going to have a runny nose. That's one thing they won't have. It's more like chest congestion. You're going to hear more of like rhonchi in there if we have it all loose in the lungs. Cystic fibrosis, respiratory signs and symptoms. And it's a little bit of everything. These children have what I call a petri dish for that mucus at the bottom of their lungs, this thick mucus, and it grows infection like crazy. In fact, you will see these children get antibiotic aerosols I think your gentamicin aerosols are commonplace in cystic fibrosis children, and they're going to be having all that respiratory distress, the retractions and the flaring and the coughing and all of these things, difficulty to get air out and air in and keeping it moving. So aggressive chest physical therapy is needed. Signs and symptoms of esophageal atresia or tracheal esophageal fistula. Esophageal atresia means what? The esophagus doesn't connect to anything. A is without. So there's no opening into the stomach. And then you have a fistula between your trachea and your esophagus. So if you eat or you swallow mucus, it's going to go down the esophagus and across that little tube, the fistula, into the lungs. And it's going to be like mini aspirations. So you're going to see drooling. They can't swallow. Once that esophagus fills up, it's going to overflow, go in the lungs, come out the mouth. They're going to be choking and coughing. Okay. And these kids are not eating at all. These kids are NPO. These children, if you feed them, it's going to go in their lungs, cause aspiration. Which of these is not a sign, symptoms of tracheal esophageal fistula? Which is not? And I mentioned earlier this symptom here and what it was. And it's that current jelly stools. Yes, that is intussusception. Good job, guys. Absolutely. Patients with esophageal atresia and tracheoesophageal fistula may have which of the following signs and symptoms? So remember, they can't have anything to eat, everything that goes in, even their normal mucus in their mouth, right? You're always going to produce saliva. So they're going to be coughing, choking, and they're going to be turning blue. Startling reflux. That's the word that's made up. Startle reflux is when you jump as an infant, when you hear noise. Impetigo teaching. What is impetigo? My grandson had it on the back of his leg. Mother thought that he scratched insect bite too much and it was getting ooey and juicy, but it was spreading. Why did it spread? Well, impetigo is a really serious staph infection. It's contagious. How do we treat it? Well, you take those crusts off and then you put antibiotic ointment on it and oral antibiotics like cephalexin, Geflex, typical for any skin things. The thing with that cephalexin, make sure you watch them. It could cause diarrhea. This is one that you might have a child on some probiotics for that, but it needs on topical and oral antibiotics for it to go away. Teaching a child with impetigo contagiosa, what are you going to teach them? And you're going to soak it in this Burrow solution. It makes the crust dry so you can take it off. It's actually painful. My grandson, to do this even after it was soaked, it hurt him. So we had to take it really, really easy with him. But if you don't take the crust off, that antibiotic ointment's not going to get in there where it needs to go. A multi. What are digoxin heart rate parameters for an infant and a child? Like, what would you say? I can't give that digoxin, and I need to tell the doctor about this. So infant normal heart rate for a brand new infant's 140 to 160. By the time they're 1 year old, it could be 120 is their normal. So if it's below 100, there's a problem. Now, as a child, as you get older, a heart rate usually runs about 100. If it's getting to be below 90, again, there'll be parameters set by the physician, but just know that infant, child, adult, there's different parameters. And that may be the only symptom that you get that this child's going into digitoxicity. So how do we do it? Well, apical pulse, 1 full minute, whether it's an infant or an adult. Digoxin requires an apical rate, heart rate for 1 minute. Is that what I just said? And absolutely, that's what we do. And that's the mainstay for digoxin. What might the infant experience? When must the infant experience physiologic anemia? Well, infants, they're born with mom's hemoglobin, mom's antibodies, right? And we know that blood cells don't last forever. And they start to die off, and the infant's not making any blood cells yet. And that's usually about 2 to 3 months, okay, that we start seeing their hemoglobin hematocrit go lower and lower. You're born at 14 and 42, okay? And all of a sudden it's 10 and 30. Sometimes by 6 months, you'll see it 9 or 8. And we'll say, okay, we'll just maybe give them iron if the kid looks symptomatic or not gaining weight because they're tiring out, because they're tired with, no oxygen in the cells. But about 2 to 3 months, we start to see that. What causes rheumatic fever?
What?
Bacteria.
Yes, it is. And what sort of bacteria? It's going to be strep that causes it, but it's that immune system that, because it wasn't treated, it
Did she just freeze?
Yes.
I think so.
Are we the only ones on here?
She got kicked out because her name's no longer there, but there's another host. This Bethany Styles is another host, but she's not on here. It kicked her out or something happened.
I'm going to try to email her, guys, to see if she by chance emailed me. Okay, so hold tight.
Oh, thank you, guys. That's what you call all the kids are all on all of the electronic devices. I apologize, and it just kicked it. Let's continue. What sign is indicative of respiratory distress in infants? And this is something that if you're going to see all of these symptoms, this infant is ill. This is probably when I hear this, I get nervous, and I don't get nervous much when it comes to children. So if they're flaring out of their nose and after each breath they're going, that is a grunt. It's like after their breath, and it's very distinctive. And of course the retraction, all of that stuff is part of it, but the grunting and the flaring is what's making me really nervous. Multi. Identify the cardinal signs for respiratory distress in infants. There are a whole bunch of them. Which ones? So their heart's going to get faster. You're going to see that nasal flaring going on. You're going to see the retractions. A lot of times you see it supraclavicular in between the two clavicle bones. It's very significant in children. You don't see it in adults. Pulling to the back, as we call it. And again, that grunting. If they're apneic, that's beyond respiratory distress. HP schedule. Who gets this? And this is your 11 to 12-year-olds. And I've had parents of boys say, should they get it? Absolutely. Give them the both, and then we're going to prevent it. Symptoms of diabetes mellitus include polyuria, polydipsia, hypoglycemia, weight gain, and yes or no. Polyuria, polydipsia, hypoglycemia, weight gain, and fatigue. No, it's going to be hyperglycemia, weight loss that you'll see with them. Remember, there's diabetes mellitus and diabetes insipidus. They're both different. Remember, diabetes insipidus has nothing to do with blood sugars, has everything to do with urine, which is polyuria, right? And polydipsia. Now, diabetes mellitus, they're also going to be hungry too, polyphagia, right? But polydipsia, polyuria are insipidus, and it's nothing to do with sugars. Polydipsia in diabetes is caused by what? Like, why are they hungry? Why do you think? I mean, if we get a child in with a high blood sugar, number one, the first thing we're going to do is give a bolus of normal saline. We want to take those high blood sugars and dilute them, right? Another way of saying that is osmolarity, which means too much blood sugar in there. The body don't like it. So this child is trying to drink, trying to get it low, but they're eating, so they're still getting the sugar in, so it never comes low. That's why they drink. What causes autism? We don't know why. We don't know why. Usually it's boys. We usually diagnose them about age 3, 2, 3. Before that, we'll have maybe thinking possibilities, but it's really not usually diagnosed till that time. We don't know. Could be due to trauma, could be due to hypoxemia, prematurity, but we're not sure. I wish we did know. We could cure it. Signs and symptoms of autism. So these are children that cannot look at you. They don't like that. They don't like touch, sound, noise. And they're all into these repetitive sort of things, or they'll repeat the words over and over again. And also they are hyperactive and constantly going. They don't sleep much either. Part of the whole symptoms of autism. Autism affects which areas? It affects every part of their life. And these children, we can get them to be perform more in normal function with early intervention done as early as we suspect with speech, physical, occupational therapy. And some of these kids can do really well by having that training. And I've seen it, I've watched it with some clinicals that I've done with it. Most common leukemia in children, which one is it? And it's actually there's 2 leukemias here, and it's actually the easier to cure. And it's the ALL. Now, AML is the other leukemia. It's higher, really hard to cure that one. So you have lymphocytic and myelolytic leukemia, and the cell is easier on the ALL side to cure. And kids do really well with leukemia today with treatment. All of these signs and symptoms are seen in a patient with acute myeloid leukemia, except I had my next door neighbor go to the ER. Complaints of pain in her knee, bruising, this rash, fever, and just feeling blah. And that's all they got. And she was diagnosed with ALL. Very much the symptoms of AML or ALL are about the same. Has nothing to do with their urine at all. Nothing to do with it. It's more that symptoms that you see. I'm trying to put those pieces together. And you'll see white counts really, really, really low. There's no immune system at that point. Which of these following signs and symptoms are most common in the initial phase of leukemia in a child? Again, that sore throat, the high fever, that low-grade fever is what you're going to see, most of them. Sometimes a sore throat might be part of it, but it's that fever, low grade. And it's just enough to be uncomfortable with them. It's not going to be that 104. Actually, when you see those high fevers, it's usually viral. It's usually not that bacterial or leukemia. A multi. Nursing care for a child status post tonsillectomy include we're going to be giving them their pain medicines. They used to give more of a hydrocodone type of these to these children, but now we just give Tylenol. We have found that works well. And the other one, they were actually having overdoses on it. So we don't give that anymore. Gum, why do they give gum? Especially on older children, has to do with their eustachian tubes become really full and it helps relieve the pressure in the head. Ice bag is good. Cool stuff is good in the mouth, nothing spicy, no orange juice. And first thing that I'd give this child is maybe a couple ice chips, because that ice in the mouth would be really good. Or a popsicle that's not red, anything not red. A child post tonsillectomy is swallowing every 2 minutes. Why? What are you going to do? Why are they swallowing like that? So we know that we're not going to go in with a tongue depressor in the mouth, but we could just open the mouth and look, and you could see the tongue is full of bright red blood. Now, I've actually seen a kid go into hemovolemic shock, as in so much blood and vomiting came out of her 7 days post tonsillectomy, requiring resuscitation and boluses of fluid. And she had to go back to the OR and get the area cauterized. Just think about it. They've removed these 2 pieces of skin. They've cut them, cauterized them, and sometimes they can leak. So if they're swallowing, there's a problem. So just look in the mouth, just very easily open their mouth, nothing big, just you see the blood, this child needs the doctor to get in there to look at it. Probably is going to go back to the OR. During a cystic fibrosis sweat test, what 2 electrolytes are being searched for? And they say abnormal transport, as in these children, you could lick their face and that you could taste salt. Now, I'm not telling any of you to lick a child's face, but if a parent did, they would actually taste, salt coming out of their pores. They're losing sodium and chloride. Well, what's that telling you about the diet on these children? You are never going to hold the salt shaker on these children because they're losing it like crazy, okay? Sweat test helps diagnose cystic fibrosis. Yeah, does it? Absolutely. That's a test that we would look at. A lot of times these children are born, and one of the symptoms that we would be looking for cystic fibrosis is if they didn't have a bowel movement within the first 2 days of life. This is one of the tests we would be looking for to see. And if we find it positive, then we know why they're constipated is part of the symptoms of. What is the treatment for nephrosis? Well, what does nephrosis mean? Isn't that a kidney? That means something's wrong with the kidney. What do you think about when you think of kidneys? You're going to think kidneys, you always worry about high blood pressure, for sure, when you think kidneys. Another thing, you have an ostis, an inflammation, something's going wrong. Let's give something steroids to calm it down, stop the swelling. And usually that nephrosis means that they're not getting rid of urine the way they should. So we're going to give something to help them urinate, diuretics. It is not an infection. It's not an itis. It's an osis. The medication Alvacet is used to treat fungal infections. Do you know Alvacet? What is that? This was one of the words of medication that was on your, what I looked at on the HESI report. I'm like, oh, Alvacet. And it's used for fungal infections. What sort of fungal infection would you think? A multi. How should a parent check for pinworms? Young kids like to play out in the dirt, and the dirt goes in the mouth, right? And we know there's going to be worm eggs in dirt. So it's possibility that a child could get pinworms. And at night, when it's dark, you go in, you can, open the buttocks and you can see tiny little dots of white. And that's actually those pinworms. And what they do is they tell you to put a piece of tape there, take it off, put it in a jar, bring it to the doctor so they can absolutely diagnose it. But this is when they're going to be given medication and will get rid of those pinworms. Which of these medications are not used to treat pinworms? A lot of good ones here, huh? Some of them you've never heard of, right? Well, you never heard of it, it's not. So Albraxam. Now, the other medications are more for antifungals. Think that ZOLE, it's something that you might use for pinworms. Anabolic steroid side effects include high blood pressure, jaundice, acne, increased cancer, and what? I mean, this is what the bodybuilders like to use, right? And there's problems with it. And not only those things, it affects heart valve, because the heart muscle, it's dangerous in the long run, but it does stop and it causes shrinking of testicles. and they get these aggressive, violent mood swings. So it is a very dangerous drug to try to use and abuse, just trying to be the biggest, strongest person of any sport. And last question, oxygen or mistense have a flow of what? Remember the first question was all about a mistent, that oxygen tent, that mistent. How much oxygen should you be flowing in there? I think. So you need enough to keep air in there, because remember, you're breathing, right? And if you just breathe in all the oxygen, you're just left with carbon dioxide. So you want to make sure there's enough flow in there. Oh, good. All right, so we've had our first HESI big review on the Kahoots. Rich, good job, Rich. Shabria, look at you, Shabria. I told you would do well. Number one, we got an S, IS, and Taro and a jet. So what I want you to do is go look at your grade books, everybody. Tell me if there's anything you need me to look at so I can do that. Or send me a message and I get back with you pretty quick. And any other questions by anybody else? Thank you so much for being patient. Sarah, sometimes internet goes out. That's my other grandson. He's my 9-year-old grandson. Sometimes the internet goes out and there's nothing you could do about it. The students do wait. They're really good with it. I quick ran to the ladies' room, so I was lucky at the moment. I appreciate that. Anything by anybody, or you're all good?
I got a question.
Sure.
Is it too late for us to do any of the, like, say for instance, like the NCLEX questions? Is it too late for us to redo any of them and get a better grade? Or
Yeah, no, you can't redo anything, but you can get this week's stuff in on time and do your best. Everything else is too old. I looked at that before we started.
okay.
You're supposed to get it in that first week. And if you look at actually the initial PowerPoint that we go over, it says once NCLEX are submitted, you cannot return them back in.
Well, it's not
Okay.
me like specifically, but I was just asking.
That's okay. You're looking out for your buddy, huh?
I had a question as well.
Sure, Jamie's.
How does that myelomeningocele, I don't know if I'm saying that right, how does that differ from spina bifida? You know what I'm talking about with that?
It's the same type of thing.
So it's the same
Type of thing. They call it all different names, but it's because the nerves weren't born where they should. Good job.
Because when you was explaining, I'm like, that sounds like that, but okay. Right, that's
Good
all I
job.
was saying. Thank you.
Yes.
I have a question. So for Sunday text review, are we doing another Kahoot?
No. Sunday's question and answer that I'm doing, it's a bunch of concepts. It's, I think, 17 different concepts and sub-contents underneath. And I'm just going to describe them, help you think how to answer questions. If we're talking about, there you go. Yes, ma'am.
Okay.
Yep. 2:00 on Sunday Eastern time. I'll be here. It's about an hour and a half at last. This is the second time I've done it. I include RN, PN. You both study the same thing. There's not much difference between you. Okay. I mean, I learned my best nursing from PNs. That's how I became a good RN. So if you guys become the best as PNs, you're going to teach someone like me that I can come back and teach you. So, do your best that you can.
Do we meet with you again after the HESI? Because I know everybody's HESIs are different times.
Next week, there is no class. It's your HESI is your class. Week 12, we can meet. Now, if you want to meet on another day and not Friday, we can meet. It's like 10 minutes. And all I do is I ask everybody, is there any grade you don't like, something I need to look at? Maybe I misgraded, I didn't see a return, something. And then for you to do your evaluations. Tell me how you feel, course evaluation. What could I do better? And please tell me honestly, I don't want you to say, oh, she's great. I don't want to hear that. I want to hear, you could have done this better, or I could have done this, or this might help, because that helps me be a better professor. And that's what I want to see. Okay. And that's all we're doing today. It's not a big, long class. We did a short class today. We got what we needed done. So I appreciate your patience during today and good old internet up here in Central Florida. So
Okay,
it's been a pleasure. I'll see you on week 12.
Okay, I have a question.
go.
So we have
You
class
guys-
at 12?
Week 12.